Hey guys, Salim Razaya here of Rebel EM, and I wanted to give you guys 5 DKA myths or things you should think about when dealing with DKA. So myth number 1 is we should be doing ABGs instead of VBGs in DKA, and this couldn't be further from the truth. There's been enough literature out there that the pH and the serum bicarbonate are almost equivalent when we compare VBG to ABG, especially in DKA patients. Plus, ABGs are more painful, and there are potential complications with ABGs. So myth number 1, do VBGs, not ABGs when it comes to DKA. Myth number 2, after IV fluids, the next step is to start insulin. And this is going to be a huge mistake if you just start insulin with your fluids. The first thing you actually want to check are, what are your electrolytes? Specifically, what's your potassium? What's your phosphorus? And you want to start replacing these or start shifting these before you start your insulin drip. So for example, if you have a patient with hypokalemia and you start insulin, you're going to make them more hypokalemic. So replace electrolytes first, magnesium, phosphorus, potassium, before initiating your insulin drip. Myth number 3, once the pH is less than 7.1, give sodium bicarbonate. And there might be a patient where bicarbonate is correct, but I would say more often than not, all bicarbonate is doing is making the numbers look better. It's making you feel better. And there's evidence to show that we get transient improvements in pH, but then that all wears off. And so when you have a patient that's already Kussmaul breathing 40, 50 times per minute, all you're doing is taking that bicarb and converting it to CO2, which means your patient has to blow that off when they're already working maximally. So I would hold off on your bicarbonate in DKA. Myth number 4, we should bolus insulin before starting on an insulin infusion. Now, there again might be patients where a bolus is appropriate, but for most patients, you can just go ahead and start a drip. When you do the bolus, you're going to make your potassium a lot lower. You're potentially going to make your patient hypoglycemic, which means now you have to stop the drip and start all over again. So just start with an insulin drip, 0.05 to 0.1 units per kilogram hour. Now I said 5 DKA myths. I'm going to throw a bonus in there for you, and that is this concept of euglycemic DKA. And people think that this doesn't actually exist, but that's refuted by case reports and case series. And we're certainly seeing more of this where it's kind of a misnomer to call it euglycemic DKA because these patients probably have sugars in the 200 or 300s. So the key here is that the nice thing about it is you treat it exactly like you would treat DKA, except the IV fluids that you choose is a dextrose containing solution. You just start that a lot sooner. So maybe D5 with half normal saline and 20 of potassium chloride. So you're going to start your IV fluids, but they're just going to be dextrose containing instead of your typical lactated ringers or normal saline. So there you go, 5 plus a bonus myth. VBGs over ABGs in DKA. After IV fluids, replace your electrolytes first. Just say no to bicarb and bolus insulin for most of your patients with DKA, and euglycemic DKA is not a myth. I hope you guys find those valuable, and I hope you have an amazing conference.